Okay, so this is the first lecture in our paeds series. This is going to be a talk on the airway and then down into the chest. First case is a plain film of the neck. So just some gamesmanship here. You get a plain film of the neck in a kid. There's only a couple of things it's going to be. Especially if it's the frontal view, it's either going to be this right here, which you probably figured out now is a steeple sign, or it's going to be a little bit asymmetric, like a subglottic hemangioma. Now that would be a little trickier, but that's the only two things you can really show on the frontal view. The lateral view, you got a couple of things on your checklist. First place to look is here, because that's the most obvious. It's the epiglottis. The next thing to look at would be if these prevertebral soft tissues are too thick. And then you're thinking like abscess, and you want to recommend a CT. Other things they could show you would be big tonsils, or a bunch of frothy shit in the trachea, like a exudative tracheitis. Lastly, and probably the most unlikely, would be a foreign body. So just running through that. So there's only two things here. There's probably four here. This one, that one, big soft tissues, tonsils, exudative stuff in the trachea, or foreign body. So that's croup, steeple sign, and epiglottitis. Now here's the follow-up, which is the epidemiological trivia with regard to these things, which is slightly different. This would make an excellent follow-up multiple choice. So what's the typical age for croup? This is someone who is between 6 months and 3 years, relative to epiglottitis, which is somebody that's usually a little bit older. The etiology is the second follow-up question that could be asked. And remember that croup is typically viral, and that epiglottitis is typically H. flu. So this is something else, just for real-life purposes, is that you don't diagnose croup on x-rays. People try to do that. Sometimes it's silly. The reason that they even got the x-ray was to look for this, epiglottitis. That's what they want to know, because if you go messing around in somebody's mouth when they've got epiglottitis, you can lose the airway. Croup is a clinical diagnosis. It's common. It's in this age group. You know, they got a barky cough and all that stuff. And then you don't have to see it's not like it's not croup, no steeple sign, not croup. That just happens to be something that's seen sometime. The purpose of the x-ray is to look for other stuff other than croup. Let me back up and make a point. That's for real life, by the way. For the purpose of multiple choice, steeple sign equals croup. And you are diagnosing croup on x-ray. And in everything else. All right, moving forward here. Next, so this is just the purpose of this is just some anatomy here. So that structure with the red line around it, that is the epiglottis, right? And right next to that, we've got lingual tonsils, palatine tonsils, and adenoids. So you could get a what is it question just based on anatomy, and those are the tonsils are tonsils, but they have different names to them. So that's at least worth knowing that much. All right, this is something that I alluded to earlier with regard to the frontal x-ray. Remember, there's two basic things that you're looking for in this frontal x-ray if that's the one you're shown. So especially if it's a frontal-only x-ray, there's only two answers. There's this one, which is symmetric, and that's croup, like that. And then there's this one, which is sort of asymmetric, and that, if you remember I mentioned, is the subglottic hemangioma. So just taking a look closer here, this is sort of like the gas outline. Sometimes you can see this. Croup is symmetrically pushed in. These are sort of outward convexity here. These have been pushed in with edema. And then if it's asymmetrically pushed in, then you're dealing with a subglottic hemangioma. So what is a subglottic hemangioma? It's a common thing. What it would look like on CT is that. It's taking up the contrast. It's a vascular thing. It's not the thyroid. Those are more lateral, and there's one on each side, typically on one side like that. For the purpose of gamesmanship, if I say subglottic hemangioma, you're going to associate that with a syndrome, of which this is a part of. This is a buzzword, torculo-lambdoid inversion. You may have seen that written someplace before. So, what is a torcula? So these are venous structures in the head here, just to orient you. All right. That right there, that's the torcula. Some people will call that a confluence of sinuses. That would make more sense. Torcula is a word that's used to confuse people when they confuse people who are learning still. You're using the more fancy of the two anatomy terms. So that's the torcula. Another way to show the torcula would be this, in a delayed angiogram. So what is a lambdoid? That's the name of the posterior suture, this yellow one here, or in the back of the head here. This is the front of the head. There are the eyes. Back of the head, lambdoid. So what does that actually mean? So here's your lambdoid suture. Note the relationship between the torcula and the lambdoid. This is normal. So what if they invert like that, where you've got torcula above the lambdoid? That's something that's seen in the setting of a high tentorium, and that is a buzzword for a Dandy Walker malformation. So the syndrome that I was alluding to is this face syndrome, or facies. Subglottic hemangiomas and posterior fossa malformation, specifically the Dandy Walker malformation. Those are the two that I think are most likely to be shown together. And those are the only ones that I would remember. So if you see those two together, or you see one, look for the other kind of deal. That's all I would know about that. All right, moving on to the chests. These are really tricky, right? People hate these things. I'm going to try to make it simple, at least for multiple choice. That's the nice thing about multiple choice, is that you don't actually have to know how to read these things. So here's one of my strategies that I use. I like to look at the history that's provided, if they're nice enough to give me any. So let's do some buzzwords. I say post-term, you say meconium aspiration. I say C-section, you say transient tachypnea. I say maternal sedation, you say transient tachypnea. Remember that these things, you're not getting that squeeze through the vagina that's squeezing the fluid out of your lungs. I say premature, you say RDS. That's an easy one. So let's practice. So here's an example question. Notice that it's just a bunch of filler, blah, blah, blah. It doesn't matter. The only thing that matters is this right here, right? Post-term. So I said post-term. And they can show you an x-ray, but it doesn't really matter. They could show you a picture of a shoe. With that history, with the post-term history, you know that it's not going to be that for sure, because that's a preterm thing, right? And this isn't classic unless they said she was sedated or she had a C-section. It's instead, we're looking at this, right? Meconium aspiration. So, boom. It's much more likely. Hanging out too long. Another good history for that would be hypoxia. If there was some kind of an issue or it was a protracted thing with hypoxia, you poop yourself. If you've ever choked anybody unconscious, occasionally they will poop themselves. So it's like a hypoxia thing. All right, now let's look at the ventilation approach. So we can have hyperinflated lungs, this orange arrow up, And those are the three things that you think about with hyperinflation: transient tachypnea, neonatal pneumonia, and meconium aspiration. This confuses people. Sometimes they're like, why would that be hyperinflation? It's because there's a ball valve phenomenon that occurs that actually traps air. And then the opposite would be a low lung volume, and that's traditionally RDS and beta hemolytic pneumonia. So notice that traditional pneumonias have hyperinflation. This one tends to be with decreased. And the way that I remember that is you didn't get checked for you didn't get your good prenatal care done, so they didn't know that you were positive for this, and that tends to happen in people with low socioeconomical status. So low socioeconomical status, low lung volumes, beta hemolytic pneumonia. Now, distinguishing between these two, remember, infections sometimes so if you have pneumonia, it's common to have a parapneumonic effusion. RDS won't have that. So if you have a low lung volume case and you've got both RDS and beta hemolytic pneumonia as options, pick the one with, then look for pleural effusion. So common association with meconium aspiration, remember this is an increased lung volume case, is the pneumothorax is common. It's so common, in fact, it's almost half of the time. So between a quarter and a half of the time. All right, next case here. All right, kind of non-specific. You're seeing some mediastinal shift a little bit right in this direction. Something going on here. And you get a CT. So what is it? How do you tell the difference? And I will point out this structure right here is how you tell. So by definition, a sequestration has arterial feeder from the aorta. So you're looking for a vessel coming off the aorta. That makes it a sequestration. Okay? And it has, of course, no connection to the bronchial tree. It's an accessory lung, but it's not really a functional one. So thing to know about sequestrations are there are two types, and because there are two types and they're slightly different, they lend well to multiple choice. The intralobar type is much more common. It's about 75%. It presents as an adolescent or a young adult with recurrent pneumonia. Extralobar is more associated with other stuff, so it tends to present earlier in infancy. Think about congenital heart disease, especially cyanotic heart disease with extralobar sequestrations. Okay. So looking a little lucent here. Show you a CT. So this is congenital lobar emphysema. And I want to show you the classic way that it's shown, which is in a series of x-rays. So day one, you actually, instead of seeing something lucent, will see something more dense, like almost like a consolidative opacity. And then as you follow that, becomes less dense, and then it starts to become lucent. And then that lucent area starts to expand. So something like this. So what's actually happened is it starts out and it's fluid filled, and then as that fluid clears, then you start trapping air more and more and more progressively. So that's the classic congenital lobar emphysema. Now let's talk about, this is a strategy that I use also for distinguishing between these things, is where it is located. I think this is helpful. So congenital lobar emphysema likes the upper lobe, sequestration, and of course diaphragmatic hernias like the left lower lobe. And the way that I remember that, especially with congenital lobar emphysema and sequestration, is this easy. It's easy to remember it, starting at the top and going down. That's the easy way to remember it. Now, CCAMs or CPAMs have no lobar preference, so it's not helpful. This isn't as helpful with them, but you can, it's just something nice to have in your back pocket. All right, next case here. This is a classic gamesmanship here. A, notice the abdomen is gasless. B, let's take a look at this tube up here. All right, so give me another example. That'll work too. So what I'm trying to show you is the enteric tube that's sort of stuck up high. And when you see that, you should not assume that the nurse didn't bother to push it all the way in. You should assume that it couldn't be pushed all the way in, that it was stuck there. Having a little coil at the end of it would be even easier. So next step would be a fluoro study. And you get something like this, where you've basically got what? Esophageal atresia, right? So no gas in the stomach, high nasogastric tube. That's how it's shown. If I say esophageal atresia, there's a couple of things you need to know. One is there's a piece of trivia that's actually practical. They want to know whether or not there's a right arch or not, because that will just change their surgical approach. So it's important to look for that in the setting of esophageal atresia. So there are several different types of tracheoesophageal fistulas. You'll hear them referred to with various different letters. The named ones are the so-called N-type fistula, which, if you use your imagination, sort of looks like an N. This situation is the blind-ending esophagus with the trachea attaching directly to the stomach. As you would imagine, this is going to end up putting a ton of air in the stomach. And then you can just have a blind-ending sac of the esophagus without any communication between the trachea and the stomach. This is going to end up with no air in the stomach. And then you can have an H-type fistula, which has a communication like this. Actually looks like the letter H. And this is not common, but because it has a named letter, it's probably the one that you hear about the second most, N-type and H-types. These two will put a bunch of air in the stomach. This one won't. Now, this is probably the highest yield point with regard to tracheoesophageal fistulas. So when I say tracheoesophageal fistula, you will say vacteral. V for vertebral anomalies. So, in perforate anus, vertebral body anomalies, cardiac stuff, tracheoesophageal fistula, renal anomalies, and limb anomalies. So, you call it a vacterel when you've got 3 or more of defined anomalies in the patient. The heart and kidney are actually the most commonly involved. Notice how high percentages those are. So it's usually heart, kidney plus blank. Heart, kidney plus one of the other ones. Now, for the purpose of multiple choice, it seems like this is the easiest one to show. This is an easy one to tell you about. This is an easy one to show. So it's sort of the opposite. This is an easy one to show. The ones that are more difficult to show and sort of less specific are the cardiac and renal ones, even though in the real world they tend to be the most prevalent. All right, next case. So another chest x-ray. This one's funny looking, right? We've got this sort of elevated looking thing of the thymus is elevated and sail shaped, but not just any sail. This is a spinnaker sail, or an angel wing sign, some people will call it. It's basically air outlining the thymus. This is an antmini, or a sign, known sign for pneumomediastinum. Now, you may be thinking to yourself, I thought the thymic sail sign was a normal thing. That's a different sail sign. So this is a normal thymic sail relative to the spinnaker sail. So something like that versus something like that. So the triangle, the one that John Kerry would be riding is on his windsurfing thing is this one here. All right, so next case, companion case. Remember, that was a pneumomediastinum case. This is another pneumomediastinum case where you've got this continuous diaphragm sign. This is another classic way to show pneumomediastinum that's not as, it's obvious when there's air all over in the mediastinum and there's air in the neck and stuff. It's obvious. I wouldn't expect it to be that easy. The tricky ones are the spinnaker sail and the continuous diaphragm. All right, I'll tell you that this person is a toddler in age. You can look at their arms, see, they're just a little kid. And what you've got here is a unilateral lucent lung. So when I say unilateral lucent lung, especially in a toddler, you are thinking about a foreign body. Now here's the trivia you need to know, aside from that, is that how do you prove it? If you put the kid on his side, normally if you lay a kid down, whichever side they're on is sort of getting compressed by their body weight, and you would expect it to sort of white out a little bit. But in a situation where you've got air trapping, it's going to stay very lucent. So a hyperlucent lung that stays lucent even when you're laying on it. So some ways this could be asked would be, they could put the kid on the right side down, and they could put the kid on the left side down, and they could say which side's a foreign body on. If you're laying on the lung and it stays hyperlucent, then that is the lung that's got the foreign body on it. Another way that's probably less common way to show it is under fluoroscopy, where you've got pushing of the mediastinum away from the involved side under expiration. So the mass effect from that air trap lung is pushing the mediastinum away. All right, so this is in the chest, and this is a pediatric case of a BFM. So it's good to have a differential for a BFM in an adult and a BFM and a kid. So this is your kid BFM. You're thinking, what is a BFM? Is a term that was used where I trained. Some people will call it a BAM. So BFM is a big fucking mass. Some people will call it a big ass mass, so a BAM. BFM or a BAM. So under the age of 2, in the chest, I want you to say pleuropulmonary blastoma. Around age 10, think about an Askin tumor or Ewing's or peanut, sort of 3 words for the same thing. So, and Ewing's, of course, is a bone tumor, so it would be nice to see the rib getting chewed up. All right, so that is the end of this first part, and then we will continue on with GI.